Hello, everybody. Welcome back, and we're going to spend some time today talking about and working through the dissociative disorders class in your DSM. You may have noticed that we're not necessarily going sort of, I guess, chronologically through the DSM-5 TR. In fact, this dissociative class, which in our course follows the class of disorders known as the schizophrenia spectrum and other psychotic disorders. This class follows, dissociative class follows the trauma and stressor-related class of disorders for reasons that I think will become evident momentarily. The reason that we have paired the dissociative class with these schizophrenia spectrum and psychotic class is that oftentimes psychosis and dissociation are conflated or confused, mistaken for each other. And so we wanted to make sure that you had a good working sense of the difference between psychosis and dissociation. And the way that I would describe that is that you'll remember from previous reading and previous videos that psychosis really is understood as a break from reality through either false beliefs or delusions or false perceptions or hallucinations. These are phenomena that occur for a person without environmental evidence. And so they have more of a reaction to how a person is interacting with other people and interacting with the environment in general, but they maintain a sense of who they are, which is a segue into the key criteria of dissociation, which I would describe as a break from a sense of self. So psychosis being a break from environmentally based reality or external reality as it is experienced by the self. Dissociation is a separation from the sense of self, and which has impact on how the person interacts with the environment. It is quite often the case that dissociation occurs in close association with traumatic events. And I think an interesting aspect of the dissociative class, and I think why it follows the trauma and stressor related class, is that there's such a close relationship. It is quite often the case that people dealing with stressor or trauma related disorders will also exhibit some form of dissociation, particularly in the form of depersonalization or derealization. And we'll talk in more detail about that specifier when we get to the trauma and stressor related class in a few weeks. But in this case, the other post-traumatic stress reactions are less prominent, such as nightmares, flashbacks, other mood states, arousal states are less prominent when a dissociative disorder is indicated. And symptoms of depersonalization, derealization, and or altered identity and memory lapses are the prominent features of the dissociative class. This class includes dissociative amnesia with sort of a specifier for fugue states, This class also includes depersonalization derealization disorder. And of course, this class includes kind of the mysterious rock star of the DSM, dissociative identity disorder, which has previously been known as multiplicity and or multiple personality disorder. DID, or dissociative identity disorder, has been known to be portrayed often quite poorly in television and film. And so it's important to make sure that we are maintaining a clinical eye when we're discussing these disorders for the purposes of this course, because it will be easy to be kind of thrown off the scent by mistakes made in our common discourse about this class. So let's talk briefly about just the basic elements before we kind of get into an attempt to personalize this class of disorders. So first of all, it should be stated that this class of disorders is incredibly rare. It is probably going to be the case that you will, throughout your career, unless you find yourself working for an extended period of time in an acute care setting, like a psychiatric emergency department or a state hospital. Unless you are working in those settings, it is more likely than not that you will go your entire career without encountering a client who presents with especially dissociative identity disorder, but also any of the disorders in this class of dissociative disorders. That isn't to say that you won't encounter a client with sort of serious and clinically significant memory lapses, or that you won't encounter someone dealing with dissociative symptoms like depersonalization, derealization. But the odds are you're going to encounter those through the course of another disorder, such as post-traumatic stress disorder. Dissociative amnesia, as well as other dissociative symptoms, are typically understood to be sort of a self-protective operation of the brain and mind. These things occur in association with either avoiding or minimizing the effects of distressing memories or experiences. And so keep that in mind. That helps explain the association with trauma and other stressors. Dissociative amnesia, of course, is associated with this mysterious phenomenon of the fugue state. Now, a fugue state is kind of functions a little bit like maybe sleepwalking. If you're familiar with sleepwalking, you will know that when a person sleepwalks, they are typically not aware that they are moving around. They are in a state of sleep. And so a fugue state is where a person leaves work or their residential setting for an unexplained reason, and they cannot recall aspects of their past, or even why or they got up and left, or even the event that they left. They will sort of come back to awareness in a new place and be confused about how they got there. Similar to sleepwalking. But the difference is that sleepwalking has a better understood neurological basis, and the fugue state is typically happening apart from a sleep a sleep cycle. A person is generally awake and participating in this action, but not necessarily sort of connecting it with their memory. So that's sort of a broad and perhaps oversimplified description of dissociative amnesia and a fugue state. Depersonalization and derealization disorder is essentially the same disorder that manifests as one or both of the following. So depersonalization is this experience of having your awareness almost leave your body, and almost as if you can be an observer as a third party during an experience, maybe in like another part of the room or another part of the area. An example of this might be that you are kind of going through an automobile crash, and during the event of the crash, your consciousness or your awareness is as if you are a third party, maybe above the event, witnessing it happening. So your mind has this experience like, this is not actually happening to me. I am, outside of the experience, which of course is a bit of a break from your sense of self. All of your physical parts are going through the experience. So that's depersonalization. Derealization is the experience of going through an event and your mind treats it as if it is unreal, or maybe in more relatable terms, as if you are, the event is a dream, as if you are living in a dream state. So those are the perhaps best ways I can describe depersonalization and derealization. When these two symptoms are the most prominent symptoms affecting a person, they will likely meet criteria for depersonalization and derealization disorder. These things may also show up as part of post-traumatic stress disorder, or even acute stress disorder. But they are symptomatic. They are not the most prominent symptoms. They are present amongst a wider range of symptoms when it is a diagnosis of PTSD or ASD. Okay, so that leads us all to DID, right? Which can involve depersonalization, derealization, and memory lapses, but also most prominently involves the creation of altered selves as a person navigates the challenges of their life. Again, this is sort of the new name and understanding of what was previously known as multiple personality disorder. And this is the disorder in this class that has been sort of mistreated and misportrayed frequently in media. So as a way of attempting to personalize DID and the dissociative class in general, as well as in recognition that this is the week that your first group wiki is due in the series of case vignette assignments that you have, I wanted to use this opportunity to go through a case example and walk through the vignette assignment, essentially report that you're going to be developing first with a partner and then later individually. As I mentioned in this item in Blackboard, I wanted you to read through the case example of Maria prior to watching this video. If you have not done that yet, please do that now. Pause this video and read through Maria's case example, which is provided for you under the thumbnail for this video in Blackboard in the lecture video folder. So yeah, if you have not done that, please pause now, read through that, and then come back to us. And so for those of you who had to do that, welcome back. I'm going to share my screen now and walk with you through the case vignette report that I put together for Maria. So you'll note here that I have done some strike through of the prompts in each of the underneath each of the headings, and you'll just delete that. That's just to represent deletion, but also I wanted to keep it there so that you could see the work that I've done here as an example. So you will remember from Maria's case example that she identifies as a 66-year-old Hispanic, married, straight, cisgender woman who is the mother of 2 adult children, a son and a daughter. Maria also identifies as Catholic and as an immigrant to the United States from Mexico. Maria has been participating in outpatient mental health counseling for about 6 sessions. During that time, it has become evident that Maria is very proud of her Hispanic and religious cultural heritage. She values personal accountability, and she values serving her community. Despite these assets, as you can see here, I am attempting to asset frame. So describing Maria as the responsible, proud, altruistic, and I honestly could have also indicated that she seemed to be a very resilient survivor of extensive trauma in this section, because we want to, whenever we can, asset frame, think about strengths and talents and capabilities of our client, and have that be the primary context in which we see them and the ways in which they are suffering, so that we can perhaps set our minds to better leverage their strengths in the service of relieving that suffering. So that's one way of doing that. So during that time, it has become evident that Maria is very proud of her Hispanic religious cultural heritage. She values personal accountability, and she values serving her community. Despite these assets, Maria has presented with considerable difficulty with memory, interpersonal relationships, maintaining her personal safety, and coping with the effects of extensive trauma in her life. And so, as you can see here, I have covered these primary introductory and demographic items in this paragraph here. And I will expect something similar from you in your own group wikis and other case vignettes. The socioeconomic status data, Maria is not currently, or is currently not employed. The occupational status of current husband, of her current husband, and details of her economic status and details of any economic stressors were not reported. I want to be really clear here. Do not use terms like not applicable or just sort of omit things that are not mentioned. Make sure that you state that they were not reported, because that shows that you are aware of their importance and that you are likely to follow up on that in subsequent work. That will just be something that you will benefit from doing when you are in a more professional, experiential setting. It adds credibility to your documentation and supports your own thinking process as you are considering the information that you're gathering and applying it toward diagnosis and subsequent treatment. The next step here is a really important one. It's the ability to describe the presenting concerns, presenting problems in terms of frequency, duration, and severity. Okay. So I also have noted in previous videos that more often than not, you're going to have at least 3 presenting problems. Sometimes you'll have 2. There will be times when you may have 4, but usually, and for the case, and for the sake of simplicity, keeping it to 3 presenting problems is usually going to be the case and is usually possible. In Maria's case, also I should say that this is an opportunity to prioritize your clinical focus. 1, 2, and 3 should be listed in order of priority for clinical attention. And in Maria's case, I indicated that she had varied dissociative symptoms evident in her report. So Maria presented as having great difficulty recalling certain life events, including her age at the time of events occurred, and she relied on family members to provide her with historical information detailed below. Primarily, however, Maria has presented with 4 altered identities during the course of the first 6 sessions. During the initial counseling session, Maria presented as herself. However, after 2 additional sessions, Maria's alters started presenting themselves. Over the course of 3 counseling sessions, 4 alters were introduced. Maria is familiar with each alter. However, she does not remember any of the events or behaviors while the alters take possession of her body. The first alter is Mary, who Maria describes as the responsible one who takes care of everyone. Then there is Isabella, who she describes as cheerful and can make everyone laugh. Isabella's purpose is to lighten the mood when deep emotional topics emerge. And during the 3rd counseling session, Carlos emerged when Maria began discussing a previous trauma. Carlos is described as, quote, the protector who keeps scary people and things away. And finally, when Maria was able to discuss previous trauma, Mimi was introduced as the weak one. And when Maria speaks about Mimi, she appears disgusted by her lack of strength and inability to protect herself. Mimi is approximately 4 years of age. So you'll note here that there are typically themes related to the alters, and it is quite often the case that the alters will be sort of manifestations of the client's whole self. So we can see Maria's sense of humor in Isabella. We can see Maria's sense of responsibility and accountability in Mary. We can also see the sort of self-protective nature of Maria in Carlos. And we also see the sort of vulnerable sense of the sense that Maria has vulnerability in Mimi. I know you probably haven't had the course related to theory and practice or techniques yet, but I think when you come across that course, you are likely to recognize some parallels with the concepts of internal family systems with this description of Maria's dissociative symptoms and with dissociative identity disorder in general. So it kind of walks back to when does this sort of awareness of multiple parts of a self become disordered? And I think one of the ways we can indicate that is when there is sort of a discontinuity, a sort of lack of memory, a sense of feeling possessed by these parts that indicates distress and impairment in psychological functioning. Remembering that impairment in psychological functioning is related to impairments with cognitive patterns, behavioral patterns, and emotional regulation patterns. So the varied dissociative symptoms I identified as presenting problem number 1, and we described them in detail. We described them as much as we could in terms of frequency. These things occur when Mary is faced with some type of distressing experience. Presenting problem number 2, I identified as depressed mood related to risk to self via suicidal ideation, suicide attempts, and self-injury. So during the past 3 years, Maria has attempted suicide twice. Again, that's frequency and severity, and duration. And she did it by attempted substance overdose. She combined prescription medication with alcohol. Currently, Maria suffers from SI daily without intention or plan to die by suicide. Since her early childhood, Maria has had destructive thoughts and engaged in self-injury, inflicting superficial cuts on her arms. This has left Maria at times irritable and with intermittent feelings of worthlessness and hopelessness. She also reports that she has diminished motivation for long periods of time, ranging from 2 to 3 weeks. And Maria says she finds no pleasure in her daily life. So heads up on the anhedonia. And as you can see, we describe these things in terms of, again, frequency, how many times do they happen? How long have they been happening? And to what degree do which they impact the functioning of, or the life in this case, in safety of the client. Presenting problem number 3, identified as interpersonal relationship difficulties. So infidelity by both Maria and her second husband has contributed to a lack of trust and intimacy in their relationship, which Maria desires. Although Maria is interested in her husband sexually, she reports, quote, leaving her body. That's sort of a depersonalization symptom during sexual experiences. Additionally, Maria's relationship with her children is strained. Although they speak frequently, Maria's children resent her for many of the events that occurred during their childhood. Maria acknowledges that while she met all their physical needs, she was emotionally unavailable. Maria's daughter was sexually assaulted as a teenager and holds her mother personally responsible. And Maria's son resents her for taking him away from his biological father at an early age. So as you can see here, we have described the client's problem areas, what the client's symptoms are, what are the issues that are interfering with the client's functioning, how long have these symptoms been going on, and after reading this section, it should be clear why the client has engaged in counseling services. Hopefully that is abundantly clear to you after this example. Now moving into relevant history, there is possible for there to be extensive amounts of information reported in this section. So Maria immigrated from Mexico with her parents when she was a young child. She had a brother to whom she felt very close. However, her brother died by suicide 3 years ago. Maria reports being molested by her paternal uncle around the age of 4. Maria told her mother about the molestation, and her mother shamed Maria for lying. The molestation continued for approximately 4 years. Near the age of 12, an older man sexually assaulted Maria while she was walking home from school one day. Maria did not tell her parents about this event, but did confide in her brother. Several years later, Maria fell in love and married her first husband around the age of 17. Maria's first husband physically and emotionally abused her. It was during this marriage that Maria gave birth to her children. And shortly after her son's birth, Maria's husband admitted he was gay. And according to Maria, everyone knew that her husband was gay except her. And this made her feel like an absolute fool. Shortly thereafter, Maria and her first husband divorced, and 2 years later, Maria met and married her current husband. Infidelity, as we mentioned before, by both Maria and her second husband has contributed to a lack of trust and intimacy in their relationship. Although Maria is interested in her husband sexually, she reports leaving her body during sexual experiences. Aside from her current status as unemployed, no educational or vocational history was reported. Maria reported that she has had several active medical concerns, specifically hypertension or high blood pressure, diabetes, and migraine headaches. She did not report on her health practices for addressing these concerns. Maria has been psychiatrically hospitalized twice after each suicide attempt. During both hospitalizations, Maria stabilized and was discharged with new, albeit unspecified, medication plans. Aside from her brother's death by suicide, no other details about her family mental health history or current family and mental health concerns were reported. As previously stated, Maria does not currently have intentions or a plan to die by suicide, and she cites her relationships with her children and husband as primary protective factors. Given her history of suicidality, self-harm, and presenting mental health mood and dissociative symptoms, Maria should be considered a high risk for suicidal thinking and behavior. So if you come across sort of signs of suicide risk, please make sure that you indicate them in this section. Current medications, if any, were not reported. No concerns about Maria's legal history or status were reported. And as hopefully you can see, we have checked the boxes on these items here. And so for my formal diagnosis, as you can see, I've included the ICD-11 code here, the name of the disorder. And then I've included a primary, secondary, and tertiary diagnosis for Maria. Now, just a quick heads up, you are not going to be required to provide primary, secondary, or any diagnosis on your assignments for classes of disorders that we have not covered yet. I am well aware that, of course, we are covering dissociative identity disorder and its class today, and we have not yet covered PTSD or depressive disorders. This is just a case example, so please don't worry about being unprepared in your case examples. That would be unfair, and I'm not going to play you that way. Okay, so formal diagnosis, I have dissociative identity disorder, post-traumatic stress disorder, unspecified with dissociative symptoms, and major depressive disorder, recurrent episode, and moderate severity. This is the diagnostic rationale section. It can be lengthy, especially if you have multiple diagnoses. So here's an example of what we're looking for here. To this clinician, Maria's dissociative identity concerns were the most prominent and impactful upon her general functioning. However, there appeared to also be sufficient evidence for secondary and tertiary diagnoses. As for dissociative identity disorder, or DID, Maria's 4 alters were described as having distinct sense of self, agency, with their own patterns of affect, behavior, and consciousness. This appears to indicate that criterion A are met for DID. You'll note that criteria A only requires 2 alters that meet these criteria. Maria's dependence upon the reports of relatives for important personal information and traumatic events appear to meet criterion B, that involves sort of lapses of memory. Maria appears to demonstrate psychological distress, such as disgust, or that is disgust and description of Mimi as having a lack of strength, this cognitive sort of patterns related to her alters. This seems to appear to meet criterion C. Noting Maria's Hispanic identity and heritage, her symptoms do not appear to be evidence of a broadly accepted cultural phenomenon of an ataque or ataques de nervios. Please forgive my terrible accent. This is given that no episodes of uncontrollable crying, screaming, shouting, or seizure-like behavior were reported. You will note that there is a description of ataques de nervios in the gray textbook. Ruling out this cultural phenomenon assisted me in meeting criterion D. And finally, Maria reported that and demonstrated her altered identities during session, allowing for the reasonable assumption that her symptoms were not attributable to the psychological effects of one or more substances or another medical condition, i.e. migraines, high blood pressure, and diabetes are not directly associated with dissociative identity symptoms. This clinician also acknowledges that dissociative symptoms are very often closely related to traumatic experiences, especially during childhood. Maria reported critical aspects of traumatic events and lingering effects of those experiences that, while not most prominent in her clinical presentation, appeared significant enough to warrant a secondary diagnosis of PTSD. For example, she reported directly experiencing exposure to sexual violence and serious injury at minimum throughout her life, as well as learning that her brother died by suicide. This appears to meet criterion A. She has dissociative reactions, i.e. depersonalization or leaving her body during sexual experiences, likely to evoke memories of traumatic events. That's criterion B. Her alter Carlos could be considered to be an attempt to avoid distressing memories about traumatic events, criterion C. Her memory concerns related to traumatic events, exaggerated negative beliefs about herself, and persistent negative emotional state appear to meet criterion D. And her reported irritability, self-injury, and suicide attempts appear to meet criterion C. And her symptoms began at minimum during her children's early years, indicating that the duration exceeds 1 month, which is, of course, related to criterion F. Finally, her report of episodic diminished motivation for periods ranging from 2 to 3 weeks, coupled with her reports of feeling hopeless and worthless, and recurrent thoughts of death, self-injury, suicide attempts, led this clinician to the tertiary diagnosis of major depressive disorder, recurrent episode, moderate severity. Again, we've covered all the things here that have been struck through. My differential diagnosis, other diagnoses considered were depersonalization derealization disorder and bipolar disorder 1 and 2. Depersonalization derealization disorder was considered in response to Maria's report of leaving her body during sexual experiences with her husband. This was ruled out because of the more prominent and more varied dissociative symptoms. Bipolar disorder was ruled out because there did not appear to be evidence for a manic episode. The irritable mood and self-destructive behavior did not rise to the level required to diagnose a manic episode and appeared to be better accounted for by PTSD and/or MDD. And then finally, my neurological and biological considerations, including psychopharmacology. I did a brief review of the literature and also consulted another textbook. And I encourage you to consult your texts and other resources when available to complete this section. So following a brief review of relevant literature, this clinician discovered that there appear to be no randomized controlled studies that eliminate a coherent etiology of DID, nor that support the use of medications for the treatment of clients with DID. As the DSM-5-TR points out, DID is likely to be present with comorbid disorders, particularly in the trauma and stressor-related disorders and depressive disorder classes. In a situation in which a client is also diagnosed with MDD, as in Maria's case, it may make sense for a client to be prescribed antidepressant medication to manage the depressive symptoms, thus facilitating more effective treatment. It should be noted in this case that medication management should be incorporated in Maria's treatment plan, given that memory lapses associated with DID lead many clients diagnosed with it to have difficulty remembering to take their medications as prescribed. If you do indeed use outside resources beyond the Gray and Ingersoll text and the DSM-5-TR, please do cite what you referenced. In this case, I cited Kress and Palos, Treating Those with Mental Disorders, a Comprehensive Approach to Case Conceptualization and Treatment. That is sort of an attempt to personalize the dissociative class, as well as give you some guidance on your vignette assignments. I'm looking forward to your questions and points of clarity and comments on the discussion board for this class. Very much looking forward to tracking your progress with your group vignette wikis and seeing what you come up with as a final draft. We are now in the thick of it. Now that we are in the midst of week or module 2, and look forward to supporting you along the way during this module and subsequent modules. Looking forward to seeing you in our next video. Thanks.